Oh, we don't need to get going because we didn't cut anything.
Yeah, and then the wind, as I was walking back to the house after taking the trash can out, the wind got it.
It
Not
was
going to be
70
70
here
degrees
yesterday.
like it was yesterday.
Windy, so super windy. But now today it's not as warm.
Today looks nicer. I haven't been up there yet. I've been stuck at my desk since 7, but there's sun and blue. I can see out my window. So
that's good. That's a good start. Jonathan, where do you live? I don't actually know.
I live in Parker, which is a suburb of Denver, kind of on the south end. I grew up in Colorado. My dad was the CEO at the hospital there, a little community hospital. That's what brought me out of Southern Oregon here. So he's been in the healthcare space. I tell people every time you talk to me about healthcare, it's his fault because he's the one that brought me into the industry. But it was a cool place to go to high school. I had a graduating class of 62, and then I ended up going to school, meeting my wife in high school. We both went to Colorado State up north in Fort Collins. Good beer there, Ben. That's where New Belgium's from. And
of course,
Fat Tire. When I was there delivering pizzas when I was in college, and they were nobody. They only made little 22 bombers, and they tipped in that, and then they started distributing. I'm like, I used to deliver pizza for you guys. We were in the garage, and now they're like one of the largest microbrewers. So Parker's about 10 miles south of the tech center or something.
Well, my first job out of grad school was Kalamazoo, Michigan, which is gorgeous, which is where Bell's was founded. Yeah. And it's funny because Bell's was just like a little, Tina knows this, it was just like a little house.
It's like hard to shop for beer now, right? Yeah, it's almost annoying.
So
like, I hate going to get beer. I love beer, and I hate going to get it because I'm like, I get so confused.
I don't know what's happening. There's so much. Like, I don't really know.
I'm like, I don't know, but I've been a Sierra Nevada guy for a while. That seems to be my favorite. I like their cans too. It says family owned and argued over. So
probably actually very accurate.
Yeah.
Well, yes, and I actually you're a Colorado State guy, which I did not know. I happened to be in Seattle, and my buddy and I went to the playoff
you got to watch the Rams play.
NCAA, the Rams play and then lose that game in the last second.
That was a great game too. Yeah,
Unbelievable game.
Yeah, it was sad. They would have gotten annihilated in the next round, but it was neat to have a good showing.
But it was still like they hit this. The kid hits a shot with like 3 seconds left. Tina, I know you didn't see this, so I'm gonna just relay it for you.
Reenact it. Let's go.
Kid hits a shot from Steph Curry range. Two guys in his face. It was unbelievable to go up by one. And Colorado State fans are like crying. I mean, they're going crazy, right? I mean, I'm not joking. And I'm like, holy crap, this is over. And then the Maryland guy gets it with like 3 seconds left, does his turn, and just hits his shot with no time left.
Yeah, and his shot wasn't even all that spectacular. He just kind of dribbled up there and shot a layup, and then it was like shock. You're like, what? We just lost? What the hell just happened? Like, why did you let him shoot that?
Why? Well, so Tina, why don't you guys should introduce yourselves, maybe Tina, because you don't know Tina, but Tina's like the extraordinary, my extraordinary partner in everything.
So,
but not my EA. We clarified that before.
That's right. So never understand. Yes, I'm not Ben. I was actually thinking about it because occasionally I will get messages like, could I put something on Ben's schedule? Which I'm like,
you've never told me this.
Oh yeah. So because
you arrange travel with Ben
when I do things for Leaders Forum, because I do many things, Jonathan.
Okay.
I'm a woman of many talents. But when I do work with Leaders Forum with Ben, my title, it just says associate, which like Ben likes it because he's like my associate.
It's not
no,
true.
Remember when I said I was like, I'm just going to call myself your associate, and you were like, that's cool. I was deciding the other day, I was like, I really think I need to change my title because I need to call myself something else because people get that confused. Like I'm putting lipstick on a pig, basically. Like I am your executive assistant, but I'm calling myself something else, But really, I feel like I need to call myself like vice president of trash and trinkets.
We should do that. Yes,
that's the other thing I do. But because it is, I think it is slightly confusing for people. But yeah, so I work on Leaders Forum with Ben. Basically, I run all the logistics to make it happen. Ben's the idea man, and I'm the ground forces. That's me.
Okay, so you're really selling yourself short here. First off, I'll try to do this intro apparently because
I am the ground, but I am the ground forces. You wouldn't agree with that?
Tina's got like 20 plus year history in marketing and branding and events, and she also was a publicist for the film industry and met all kinds of famous people, and she's written
he's doing
3
a better
New York
job
Times bestsellers. 3 New York Times bestsellers.
As a ghost, yeah.
As a ghost, but who cares? And she's just extraordinarily good at pretty much everything I give her and ask her to do. So it's pretty awesome.
I do lots of things.
And
I'll be the first to...
I have 3 kids, and I have 2 adult children who are in their 20s, but they like pay all their own bills. I feel like that's my shining. That should be the shining star.
That's a huge thing. Get them off the payrolls.
They're grown-ups who pay their bills and live on their own and do that. I have a 17-year-old about to graduate from high school, so that's my last.
Congrats.
The last one. So like, actually, I feel like that's probably the greatest accomplishment that I have.
Dude.
Yeah.
You are.
Yeah. So I do lots of things on a regular basis. So it's exciting.
Cool.
Yeah.
Well, I think Ben should give you a raise. That's what I think. So.
100%.
Well, I know it doesn't really work like that, but we collectively work hard around
100% for sure.
Yeah,
for sure.
It's good. I get paid in sweatsshirts.
It's not true.
I do get to pick out. I do get to pick out the merch. And Ben is jealous of the next round because I got his favorite sweatshirt for the ladies.
That is true. The ladies got the favorite sweatshirt, and the guys got like something nice.
We
always do something nice for our board, Jonathan. So something nice for our board. Yeah. And Tina, let me try to introduce Jonathan like best I can. I'll let him do that. But I think Jonathan's a man of the people. He is maybe one of those, if the most well-known rev cycle guy in the industry, and has written several books, one of which I have here and I've been scouring.
Nice, cool.
Now, to be fair, Jonathan, I read this a while ago because we were supposed to do our podcast like a month and a half ago.
Sorry, we keep kicking the can.
And I have forgotten a fair amount. So I was like, I had a bunch of questions, and now I can't remember.
There's only so much capacity in the RAM, I tell people.
So I went back in and was like, trying to okay, what did I have here?
No worries.
But no, it's really good, actually.
Cool, good.
Many years ago, our friend Doug, who Tina knows, was new to the industry. And he was like, what book can I read that would tell me everything? Because he was really he's one of the few people I met that was not a verbal learner at all. Like, he really needed to read it, I was like, I don't think there is a book. I mean, this is 12, 15 years ago. And I'm like, but I would say today, and I really do mean this, I do think your RM Advantage, which I do like, RCM Advantage book is a really good, comprehensive book to kind of walk through and understand what's happening in the industry. I just taught RevCycle 101 class, 3 classes that are RevCycle 101, my first cohort, and in 6 hours, mind you, 6 hours, I could not get through enough. You really this would have to be a supplement to it, basically, is what I felt like, which I am recommending for people. But anyways, Jonathan is, maybe explain the rest. How did you said your dad worked at the hospital, so CEO of the hospital. How did you get into RevCycle? Walk us through a little bit.
How'd you move from pizza to revenue cycle?
Pizza to RevCycle.
From pizza to RevCycle.
That's right, pizza to revenue cycle. Yeah, I think on my bio it says hospital transporter to business leader or something. Yeah, I was going to be a physical therapist when I grew up, but that just didn't pan out. My dad is a smart guy because he came from the space. He was valedictorian at his high school, went to Cal Berkeley and got his master's, and then ended up staying in Southern California, which is where I was born, and then worked in Southern Healthcare down there at community hospitals. Worked for HCA for a little bit in Portland, and then got a job out in Aspen, which is where I kind of finished high school. But when I was getting my degree, I have an undergrad in sports medicine from Colorado State. I wanted to be a physical therapist, and he said, "Are you sure?" I'm like, "Well, yeah, it sounds cool." And he goes, "Well, hey, I know someone at Swedish, which is downtown in Denver." He goes,
"Yeah, totally.
Why don't you go hang out with them for an afternoon and just follow them around?" And that was brilliant because I was like, "Oh my God, this job is horrifying to me." They were wonderful people, but I was like, I would be so bored and frustrated trying to figure out how many minutes I could spend with people to make them better and having everyone tell me what to do. Physical therapists have a really hard job. They're kind of like banks. They're very couldn't find in terms of withdrawals and deposits, in terms of how they have to transact their therapy. And I said, well, now what? And he goes, well, have you thought about doing what I do? And I'm like, your job seems very boring. I told him. And I meant that with
that
love.
went over well. I mean, I mean the nicest possible way.
Yeah, sitting in his office playing with his rubber bands and paper clips on his desk and just, hearing him talk about things I had no idea what they were. And so he said, well, why don't you go to CU and they have a master's program. It's at night. You can keep working. And I did that. I got 2 master's degrees in health administration and business. And then he knew someone at the hospital in Boulder. And he said, hey, there's this job as a transporter. You should take it. And I'm like, what's that? And he's like, you just push people around the hospital. He goes, it'll pay the bills. He goes, but to start in a hospital, and this was probably some of the best advice I got from my father. It really was, you got to start somewhere if you're going to be in healthcare. And oftentimes that's in a place that's a lot lower than what you would like. But everybody I've talked to, because I've been a mentor and things, I'm like, take that job, go do it. And I would do that job today if I could, if it paid the bills. Because I got to go to the lab. I got to go to the emergency room. I got to go up to surgery. I got to go to all the floors and meet all the nurses and imaging. And it was like an awesome episode of Taxi, in the hospital. I had fun, and I'm a people person. And it was cool. I got paid $7 something an hour, and that was my first job. I got my master's degrees, and then the hospital couldn't afford me, to be frank. I remember walking into administration and saying, hey, I can't, be a transporter for the rest of my life. The program had a placement program for administrative residencies. And I'm like, they're offering me, I forget what it was, like $35,000 a year or something to go be a resident at a payer. And I was like, I don't know if I want to work for an insurance company or not, but that's a lot more money than I'm making here. And I did it. And I wouldn't trade that for the world either. I got to rotate through every department at the payer. So medical management, provider relations, compliance, marketing. And I reported right to the CEO, and he just literally would give me little projects and say, go find out what those guys do and come back and see me in 2 weeks. And it was fun. And then I got hired in regulatory affairs and product, stayed there about 2.5 years. And then I just got sad. I think if you work for a payer long enough and you've worked for a hospital, you get sad over time. And the hospital called back and said, hey, now we've got something for you. We've got an operations role. And I came back to the same hospital, boomeranged, and then spent probably the better part of my career there, 15 years, and worked my way up through imaging as an operations manager into admissions as we were doing our Meditech ring conversion to client server. We were one of the first hospitals in the country to do that. And then the billing director retired, and they created a chief revenue officer job. We centralized our admissions. That was a cool project. We had every single person come through one door in our new hospital. And so if they were emergency, coming in for a mammogram, coming in for a lab, coming in for surgery, traumas, everything, not traumas, but like walk-in ED patients. Because you guys know, if you've been in a hospital before, the ED's dead on Monday morning, but it's freaking crazy Friday night. And the imaging and surgery schedules are completely jam-packed Monday through Friday like a bank, but they're dead on Saturdays. So it's like I had 20 people, and I needed 10 of them on Monday through Friday and like 2 of them on Saturday and Sunday. So I'm like, I'm going to cross-train you all, and then we're going to use 8. It's just spread you all around, and we created a centralized admissions and did that. And then I got scooped up about, 10 years ago from TransUnion Healthcare. And they said, hey, you're doing good things there. I was publicly speaking at the time, and like, we want you to publicly speak for us and help figure out our estimation. Actually was hired into product. And then slowly they didn't know what to do with me. I just, every job I've had, I've kind of amoebaed into other things. My job description never is what I really do. I guess it's always what I've been. So I tell people now my job's in thirds. It's a third research. So I publish books and do those things. I'm doing a lot of stuff on public policy, which we can argue about here in a minute, which is all over the place. I do it and just kind of inform the business and the market. The other third is that, informing the market. So I probably speak 20, 30 times a year, and that keeps my acumen up also, because I'm one of the few people, I'm not a vendor. People think I'm a vendor, but I really am a thought leader. And I go and sit in all the sessions and take 25 pages of notes and then write a blog afterwards and kind of regurgitate that back to the business. If I'm not behind a desk anymore in a hospital hearing all the problems, I want to hear it from the constituents that are there. And then my other third is biz dev. I think that probably justifies my existence. So I help our sales team and our product team and the rest of the business, just in terms of informing them about why our solutions are not needed. In certain situations, most of the time they are, but sometimes they're not. And then where we're not hitting the mark or hitting the mark, or where we need to adjust our operations from a strategic standpoint, and help kind of get things across the finish line. I'm actually enjoying that part the most. I miss my hospital's brothers and sisters, and I get to kind of talk to them about making a difference at the patient level from a finance standpoint. I miss that. So I know that was a long-winded answer, but that's my background. It's a fun one.
No, it's good. It's great. What hospital were you at, Jonathan?
Boulder Community. Yeah.
Boulder Community.
Yeah, they're about $500 million in revenue. They're probably $1 billion, I bet now. 175 beds, trauma 2. Nice place. They're the last independent hospital in the Front Range in Colorado. Last one. They're not owned or affiliated with anyone, and that's like seeing a deer, you know.
It's like a unicorn, seeing a unicorn in the wild.
Yeah, unicorn. Yeah.
No, these things exist.
And I love that. It was cool to not have a corporate board or anything, and the board were all local businesses. Sure. It was really cool to work in that environment.
Yeah, that's for sure. Cool. Yeah, that's awesome, man. That's such a. Would you ever have seen yourself like 20 years ago being like, I wrote a couple books? Who would have thought? You know? Or
no, not at all. And then I remember the story about the book's kind of interesting too. So the marketing director, you'll like this story, Tina, at TransUnion at the time, he saw a couple of my presentations. He's like, "You're pretty good at this public speaking thing. You should write a book." And I remember I went, "Write a what?" I go, "I'm not an author. I have no idea."
Write a what?
He goes, "No, shoot me an outline." You go of like your 10. This is how Patients the New Payer got written, of like things that drive you nuts in healthcare and why you think it's all messed up and how you'd fix it. You go, just one page, and he goes, "And we'll help you write each chapter and figure it out." And that's what we did. And it took me 18 painful months to get that first book out, but it's my favorite. It talks about, barber poles and healthcare. A lot of people don't know those things are related. It talks about how universal healthcare was presented in our country probably a half a dozen times and voted down. And if it got presented again, it would get voted down. A lot of people don't know that.
Absolutely.
Yeah. And how the tax
Every
base
7
is
years.
so screwed up here, and how there's so much greed, and how there's just disaligned incentives, and how, like, if I were, how it could get fixed, but we just won't. Like the last chapter of my first book was a Beach Boys theme. Wouldn't it be nice if healthcare was affordable?
Right.
And it had 10 things I'd change. And they're pretty polarizing things about treating healthcare like indemnity or risk insurance. Like when our kids all got our driver's license, our insurance went up. But when our kids, turn 19, it doesn't. And they're very dangerous little humans when they're 19.
Mm-hmm.
You would think that our insurance would go up and down, but it's pretty fixed, and we don't do a lot of those things.
16-year-old yesterday's.
Yeah, or when
mine
people's
turned 16
cholesterol is like 300, like, should their insurance be more than someone who's not? Those are just questions you have to ask. I don't necessarily have opinions on them, but health insurance is a fixed employment tax benefit that has really evolved into this entitlement type thing these days. And I think it's becoming expensive, and it's probably more fragile than it's ever been. So we'll see what happens. But yeah, that was how the first book came around, and people love that book. It's a fun one, The Patients the New Payer. It's a fun read because it talks just about how we got into this mess and how it may not ever get fixed. That's it.
Well, for sure. And
Yeah,
it's out there.
I mean, I'm serious.
Well, and it's everybody's.
I don't think it's gonna get fixed.
Well, it's out there. Fixed is
not
like
in our lifetime.
it's everybody's like nightmare scare story, right? Like,
Yeah. Well, I'm a realist.
it's pitched as fear, right?
Yeah. Well, and money. We're a capitalistic economy, and like if I were to write a fourth book, it would be, and I'm pitching this now, it would be U.S. healthcare versus the world. And it's, something out of like that James Bond scene you saw where they were shooting all the little green and red things and understanding who owns what country or whatever. I can't remember what movie. That's where they were getting shocked by it was a Sean Connery one. Dama Matrix or whatever it was called. Anyway, but my point is that, there's models out there that have actually done fairly well. The Scandinavia's got one, but they've got a 38 to 40% tax base, but they have a fairly healthy economy with very good health outcomes, and they've got a pretty good economy as well as far as producing goods and things. You've got the NHS, which is falling apart in Britain and London right now. It's just not doing well as far as outcomes funding, and it's had to have kind of a hybrid privatized model. Japan's got a good model. Canada's debatable. That gets compared to the U.S. a lot because there are borders to the north, but it's got its own challenges as well from a quality and I would argue delay of care standpoint, and access. There's some access issues up there. But I think if you kind of take all those pieces, it would be cool. I was at HIMSS 4 years ago, and one of my favorite sessions I sat in was it was a combination of CEOs, CFOs, and physicians from like 12 different countries, and it was this big panel, and they each talked about the funding mechanisms and the pros and cons of each. We'll see. The only way to fix it is to raise taxes or expand the entitlement programs, which would increase spend. But we'll see what happens with that. We can talk about politics now if you like.
He's like, we'll just get right into it.
Yeah.
Do you want to talk about politics? I don't know.
Yeah.
I mean, we could, I guess. Yeah. I let me just respond to your, because
Sure. You bet.
I have a what do I have? A theory? I've been working on.
theories.
I've been noodling on something new.
Sure.
And I have I see maybe like I see two things that what you said, all of which I agree with. By the way, it's like I do think it is like untenable what we've created. So there's something that has to change, and we both know universal healthcare is not going to be the answer because we just won't as a public like approve it. We've been rationing care forever. We just don't call it that. So
right.
It's just we're just another version of rationing care, right? So, but I actually fundamentally believe that employers have the biggest opportunity to make change. It's actually not the federal government because I actually don't think they could pull it off. Obama proved that by like, hey, I'm trying to do this thing, and then it just got muted down to the middle of whatever that middle is.
Right.
Which he ultimately was trying to do good things, whether you're a Republican or Democrat or neither, it doesn't matter. It's like he was trying to do good things, right?
Yeah.
So I fully believe like we were rationing care. But the employers actually have the largest opportunity to do something significant because most of them are self-funded. They're self-funded as in like they cover their own.
Yep, 80%
For some reason, we've used
insured.
insurers as like the place where all this happens. This is going to be controversial. I actually believe if we cut the insurers out the way they're formed today, actually immediately I think we save 20 to 30% in cost. And the reason I say this is because here's where I think we've gone wrong. Many years ago, we made insurance, but it wasn't like our car insurance or our home insurance or even our life insurance. And the reason I say that is because like my car insurance, I'm expecting something to happen and I'm expecting a claim to happen when I get in an accident, right? But I'm not expecting them to cover me when I need like an oil change or, hey, my battery died. How come you guys don't fix that? And I think what we've done here is we've actually mixed what I call like stop loss insurance or catastrophic insurance and just wellness insurance. We've just created this giant pool of like, well, no, we're just covering everything. And you're like, how did we end up with that? Because those are two very, very different products. Anyone in the insurance world will tell you those are very different products. There are extended car warranties that do exist. I get a call like every other day for them. That will cover you when like that happens, right?
Yeah.
But it doesn't. Again, even in my mind, I'm thinking I wouldn't call them to cover an accident. And I just had my we have a lake house in northern Michigan, and we had this huge ice storm that happened, and so there's lots of damage that occurred, and I'm even contemplating filing a claim then because I know what happens to my insurance afterwards, right?
Yeah, you might get kicked off for your premiums,
tens of thousands of dollars, but I'm like, do I want to file a claim?
Yeah.
Literally, that's my thinking, right? It's like, I'm not sure because I know what's going to happen to me after I file a claim, right? But I'm not, my generator died in the process. I'm not going to file a claim on my generator dying because it wasn't the issue. It was just part of maintenance. And actually what I think we've done here is we've just mixed the two, and we've done it for so long that people just, like you said, there's this entitlement of like, no, I have this insurance and it covers me for everything. It was like, why did we come up with that idea?
It wasn't designed for that. Yeah,
it wasn't designed for that. And insurance isn't designed the same way. If I have a catastrophic coverage where it's like I get over a certain dollar amount, like let's just say 50,000, 100,000, then I should have insurance for sure. But that is actually what insurance is for. So I actually think employers could kind of immediately change the game if they could kind of come up with direct contracting with a health system that could cover them. and then separate the two. Get a policy from Lloyd's of London that covers them in catastrophic, and then work out how to get services that would be preventative and like in total, because that's ultimately what they want. They want people to be healthy so they can continue working, right? That was the whole intention.
Yeah.
So anyways, that's my
No, I think you're right. And I mean, like Henry Ford, Boeing, in my second book, there's a list. I don't have the list in front of me, but it's about a dozen or so that have done that, where they're doing direct to provider contracting. They haven't done that other element, Ben. That's actually a really good idea to kind of, I like your approach in taking out kind of concierge medicine is what I call it. Not well, it's all you can eat. It's a buffet. It's the country chow down of healthcare in the U.S. You know, whatever I want, whatever I need, I can get it. We had concierge docs in my hospital, and they're like, you know, Mr. Smith will stay here for 15 days. And I'm like, who's paying? He's like, I am. I'm like, great. You can stay here as long as you want.
Sounds good. We'll get him some, RVs delivered. It's fine.
Going on with them, you know, that we need to do. But, you know, but I used to say the opposite to you, like United Healthcare or others. You know, this is not a hotel. I was on our committee, and I had case management reporting to me, and I was the big bad finance guy, and I'm like, hey, the payer stopped paying 3 days ago. What are we doing clinically for this patient? Most people don't know this. Hospitals are licensed as stacks. They don't even know what that stands for. I'm like, the first two words are very important. Short term, like hospitals are designed to save lives and get you the heck out of here. They're actually very dangerous places. They were brought into the world to put arms back into people, take bullets out, make your heart start again, and bring a baby into the world. Those type of things, mostly traumas. They're not a strip mall for anything you need, you know, for healthcare, and yet they've become that because there's a funding mechanism that perpetuates it, if that makes sense, to kind of articulate back what you said. And that's wrong. And that part's that's that greed I was talking about. In my first book, there's a Venn diagram that has 4 spheres, and it has the patient, the employer, the government, and the hospital, and the providers there. And it's like, they're all separate, like imagine like a molecule, and neither will they all come. And I'm like, this is the problem with U.S. healthcare. Each one of those spheres has its own agenda. The providers want to be a business and help their community be healthy. And sometimes those two things are conflicting. If you look at certain organizations, sometimes, most of the time it's the community side. They're there, especially if they're not for profit and started, that way, for profits as well. But like the government, or the employers, to your point, I'll go there right away. They didn't sign up for this. The World War II tax code put them in there. And all of a sudden this became a benefit, and now they have to compete with benefits. It's their number one cost behind labor, and it's a substantial cost. And there isn't an easy exit plan right now that wouldn't involve their employees in a very, I would argue, competitive job market right now, losing them if the benefit was substandard to something else. It would have to be super creative, super costly. Most Americans spend $23,000 a year, I think the new number is now. That's more than your freaking mortgage. And think of all the time you spend on your house and all of that, picking that out. And you spend 10 minutes maybe with your employer picking out your insurance. At most, I would argue. Here's your 3 plans. What's the deductible on each? What's my premium? Cool.
Yeah. Oh, okay.
My house, you'll spend months.
High deductible? Let me do some math here. I don't know.
And then the patients are just like, look, I don't know why all this stuff is so expensive. Healthcare's a pain in the ass. It's still really hard. It's the only industry. The example I give is you got a shopping cart and you're in a dark grocery store, and there's a doctor pushing your cart, putting all this stuff in there, and you have no idea but you can hear the clunks. And then you get to the thing and the lights come on, and the register goes, and you're hearing the beeps, the bloop, bloop, bloop. Remember those days? And the numbers are going up, and it's like 18,342. And then the person at the grocery store says, oh, these guys United are going to pay for it. You owe $50 today if you want. And then you leave. You get, if you did that with real groceries, you get tackled in the lot. But it's legalized shoplifting. I had a CFO tell me on the West Coast. It's really
shoplifting.
It's really kind of a funny term. But then the government stuck trying to fix it. They're like the referee on the football field, and they're like, flag on Medicare Advantage, fee for service paid that, you're not, 10 yards. That's what they're trying to do now. Or, hey, you got to cover insulin pens the same as you cover everything else. Remember that with Hillary? And, we're going to make drugs more affordable, or now, hey, we're spending, we're going to find $880 billion, to save. And it looks like Medicaid's the best way to get at that. Let's see if we can. And because people don't like paying these high taxes, even like you said, we're kind of rationing care anyway. But you notice each one of those didn't talk about the other. And they all need that patient or member or voting citizen in the middle to make it work. But there isn't an arc around the outside. And value-based care, if I were to draw that picture again, would probably be the satellite orbiting that stuff. But it's got to be interconnected. And we will never come off, I like saying, the fee-for-service teat. We're addicted. It's cocaine for healthcare right now. I've talked to several organizations where they're like, we love having volume. We love having surgeries. We love having patients in our hospital, and we love the revenue, and we love getting paid for doing things over and over and over again. And we don't want to know how to make money doing that. And it's wrong, right? We'll figure that out. Make
money doing that, though. That's how they know how. That's how they make money. So, I was curious to know your reaction to the news about Teladoc going under, and that they were changing, Medicare, stop paying or paying not as much for any telemedicine services. And I'm like, oh my God, how did we end up here? I still don't understand. We know it's cheaper.
Right.
So, we know it's more convenient. Yeah. Why are we not doing it? And so we don't pay for it. No one's going to do it. So now we have no services.
Right. Yeah, and it's in a fragile place. I tell people that I talk to, just like you, I have not seen healthcare in our country be more fragile in the last probably 2 to 3 years than it's been in the last 20. There's just a lot of, it didn't get talked about politically because there was a bunch of other stuff to talk about, but it's really fragile right now. Kaiser family's been running a lot of scenarios surrounding some of the political stuff that's being talked about. And you couldn't have wrote a more terrifying story, Ben. The CSRs expire at the end of this year.
Explain what that is for people.
Cost sharing reductions. So for the subsidy plans, for the health benefit exchange, so people that are on ACA or Obamacare plans, whatever you want to call them, the community health plans, most states have them these days. The government helps they go Dutch, for lack of a better word, on the premiums to help people kind of have coverage. They're catastrophic plans, though. Anyway, I would argue they probably create more debt than prevent it, just in terms of the deductible packages on them, because they're in the thousands of dollars. Anyway, they were a good idea to get people on care. They weren't a good idea to necessarily fund care over time. The ACA had its kind of wins and losses, and that's a win for coverage, a loss for debt, I would argue. Nonetheless, you don't want people having nothing. And Kaiser family's got a really cool document out there that's saying at the state level, if the subsidies went away, the impact on the state budgets that would be, and also just on the enrollment and membership. And it's pretty significant. It's impacting probably a third of the folks that are on one of those plans or Medicaid, and their premiums would go up by 200-300%. Just because of the risk pools and all that stuff. And that basically means, we'd start seeing, teen uninsured rates like we saw, in the early or late 90s, back when we thought the world was going to fall apart before the ACA went in. So we'll see.
Now, a quick word from our sponsor. Payers have instituted ever-increasing tactics to avoid or delay payment to providers. Requests for additional information, line item denials, payment delays, or just plain silence cost healthcare organizations millions each day, and providers are challenged in identifying tactics they can deploy to hold payers accountable. Switch RCM has answered this call to action by developing a proprietary and unique solution that empowers healthcare organizations to identify and calculate interest and late penalty payments across their clients' entire claims population. With a simple data lift, Switch delivers claim-level detail that allows clients to pursue missed or underpaid interest payments across their entire payer population in an effort to hold payers accountable now and influence improved payment timeliness in the future. Learn more about Switch RCM and start holding payers accountable today at switchrcm.com. Now back to the show.
Medicaid, not to get political, I think I get lots of disagreement when I make this statement, but I absolutely think they're going to touch the funding this time. There's no path for the savings that's out there from the deficit this time in the House and Senate reconciliation bills that allow that amount of savings to occur without adjusting the Medicaid benefit package in some regard, reducing the FMAP, floor, the federal matching map, changing the eligibility provisions. A lot of people don't get this, Ben, and then I'll shut up. A lot of states that expanded have trigger rules in a place that say, like, if the FMAP gets touched, they kick off their expansion and they go back. And that, it's kind of this nasty wheel that can happen. And I've been to Washington probably a dozen times talking to staffers. They're like little honeybees flying around. Like, what do you got? All right, cool. They're like a detective. They got this little pad and then they leave. It's like 5 minutes.
Just leave.
You're like,
2 minutes.
God,
yeah, thanks.
Terrifying.
Terrifying. And it's whatever bit of information they wanted to bring back, right? So
right.
It's like, well,
how should we vote?
heard this.
Like, no, I didn't tell you how to vote. I'm just telling you what not to do. And they're like, just don't do this.
Don't do this.
But I went with the White House once too with Kamala, and we were talking about medical debt, and it's a big deal. Like, these changes matter. And so I'm praying for them. I just presented to our business this morning. I'll send it to you guys after I'm done. A legislative update too on just what I think might happen and what is likely to happen. They passed that thing in the Senate last week, and it's got to go to or in the House. I think it's got to go to the Senate, and before the month's out, and it has Medicaid cuts in it. It's there, and so half of it's been passed, and the other half's going to look at it. And the Senate's always the hard one, right? We'll see. But I think Medicaid's going to get touched. I don't know how much. What I talked about this morning was it's not going to be like Medicaid's getting cut by $80 billion. It's going to be, we're going to reduce the FMAP floor by 5 percentage points. And no one knows what the hell that means except for people like us on the call. We're like, oh, so that means the states are going to have 5% less reimbursement. Where's that going to come from? They're going to run out of money, and they're going to have to pick it up. And last I checked, but the states aren't in a surplus for budget. They're all in a deficit. And so I'm actually following what the territorial folks are doing more than at the Senate level and the House level, because it's going to hit their laps, and then it'll ultimately hit the hospital's laps. To your point, Tina, in terms of just uncompensated care and debt, it's going to flow to hospitals, I think. And it'll go back to where we were probably when I was at the hospital and we were trying to manage, $10-20 million of bad debt and trying to make that number 8 or 14 million, depending on the range, and just try to cut away at it each year to get them onto some kind of plan or charity program that's managed by the state. And we'll see. I don't see a clear path.
No, I also think I've heard from multiple health systems that are actively actively planning that they're going to see a 5 to 10% reduction in revenue.
Yeah.
And that's not from volume, that's from just reimbursement.
Yeah.
And they're trying to cut out hundreds of millions of dollars in cost over the next,
just to kind of put the sandbags
which a lot of people
beach.
supposed to go starting in July. So if you think about July for the next year, like, that's where people are planning to.
Yeah.
And those aren't easy things to, like, just go do. You can't.
That was hard to find. I remember my CFO would call me and say, "Hey, Jonathan, you got to go find 2%." And I used to call it the Clint Eastwood number. Any which way you can, get it through labor, get it through your vendors, get it however you can. But we
heard the same thing from some of the big vendors. I heard that a couple of days ago, where they were saying, "Nope, people are coming to us and asking for
concessions." Yeah, we heard that too. And we can meet
these
them where we're
these
at.
are not small, these are not small things.
Yeah, but that that ripples out, and we've got numbers to meet too. We're public. We're not publicly traded, but we've got a board, and we're private equity owned, and that part's interesting for us. We've got growth curves and things like that we need to keep to, and those are pretty aggressive as well. And as we meet hospitals where they're at, we have to kind of demonstrate yield, and I would argue most of the time, at least in the conversations I've had, I'm like, we could do that, but most of our stuff was there for a reason, and it actually might backfire on you. The yield and the benefits that we've created from an impact on where you're at. And if we don't have that revenue coming to us, our investments in things like generative AI and what we're doing on the research arm and those types of things to help optimize the solutions and make them go faster, stop. And then all of a sudden we've got antiquated legacy software that looks like HBOC from 1975 again, and it dot matrix stuff.
It might be back there soon enough. Jonathan, I'm not a political person, so Tina knows this about me. So I'm I'm actually somewhat not knowledgeable in that area.
That's okay.
So when I say a statement, it's not because I have some political.
No worries.
My understanding, though, is that I would characterize this administration as not necessarily like it doesn't sound bad, but not caring about the underinsured self-pay. And I don't think they mean that. I don't think they would go out and say like I don't care about people, but I do think like they see it as like, well, just like they would like welfare. They would see it like welfare. They see Medicaid as like welfare, and it's like, and so I'm curious to know from your perspective, like, do you see them just kind of going after it because it's like, well, those people, like, and what does the end of that look like? Because I think we still have states today that never, rolled out ACA, and they're still not covering people unless they're totally disabled, right? Which is
right.
I
think that perspective.
I lived in that world, right? So it's like,
well,
what does it look
ACA
like?
It's relatively new too, right? I mean, it's only celebrated its 10th birthday a couple years ago or something too. So it's not that big of a. It's not like Medicare, that's 25, 30 years old. So you got to consider that too. That it was legislation that went through in a fairly rapid manner. If you look at how like something that big of a deal went, and then it really didn't have a long-term planning goal with it either to kind of figure out how to keep the engine running.
Sure.
And then COVID happened, which just like threw gas on the fire. And so we had the public health emergency, which, enrolled, and then that unwound. And so there's been a lot of chaos that's happening. So through the lens of like the Republican Party, which I'll do my best to kind of understand that and be apolitical, there's a bunch of different kind of trains of thought. One is there's people on the program that probably shouldn't be, and I would actually agree with that. And what I mean by that is there's folks that qualified for Medicaid at one point in their life that probably don't anymore. They figured their life out. Most Americans are fairly resilient in their workforce and try to figure. It's a small percentage, but
I think it's got to be a small percentage. But I know what you're talking about. Sure.
And that's the at-work provision stuff, which I think you're going to see quite a bit of activity in. There's about 11 or 17 states or something right now that have at-work. I wouldn't bat an eye if that number doubled. That kind of immediately, that's a cut indirectly of Medicaid if you think about it, because it's going to lower the number of people that are on it and really probably more appropriately look at the fraud, waste, and abuse stuff a little bit. Because if you're not working, you can't. Yeah.
Can I just make a caveat? Like,
sure. Yeah.
To me, that's not fraud. That's still someone that's at risk.
Yeah.
Even if I'm working a low-paying job and I'm now at work, and I could, in theory, that doesn't mean your employer's giving them coverage. Or if they are, maybe it's just way too much. I still think those people are at risk.
Yeah.
And so to me, it's like there's no scenario in which there's someone on Medicaid, and someone's going to correct me, that's making $1 million a year, right? Like those don't exist.
Scenarios where they're making $120,000 a year, $130,000, and they probably should have, like, because the re-enrollment process hasn't been as tight as it needs to be.
But like those are probably like to the 0.01%.
Yeah, it's a small percentage.
So
like
sure, get rid of those people and figure that out. But like my guess is that's not like, this is, again, reminds me of Reagan in the 80s, right? Where he makes up a story which did not exist about welfare, and this person in Chicago, which they tracked down, by the way, and that person did not make very much money at all, and it was like a full-time job to get registered 8 times.
Yeah. Well, remember,
anyways, this is another side note.
We're talking about trillions of dollars too, right? So 1/100th to 1/1000th of a percent.
It's not enough. So, like, right?
So that's why the media is not helping anybody with this, because they're like, millions of people are going to lose insurance and blah blah. And it's like when you start looking at it, it's less than 1%, but that 1% matters, and it translates to billions off of trillions because it's these little things. So that's one thing I think you're going to probably see. And yes, they're at risk, and yes, they may end up being uninsured. Yes, they may get more sick. Yes, they maybe could have afforded insurance and chose not to, and went to Hawaii or bought a car or live in a 5-bedroom house and should be in an apartment. That it gets really weird really quick.
It gets really weird
when you start talking about choices people have made to self-insure, I call it. And yes, healthcare is unaffordable, but it's usually not something that's saved for or invested in unless you're employed. And that part gets really weird when there's others out there. The other thing I think that will happen with this is that you'll start seeing some enrollment provisions change probably at the state level. We saw 1155 and 1113 waivers come out of Washington quite a bit. And those are fancy letters for the state saying, hey, I want to manage ACA and Medicaid a little bit differently than the federal government does. And I'm going to change the level of benefits to kind of curb tail or funnel some of that stuff coming through. I don't think we're going to see prolific like block grants where they pay like a lump sum. I do think they're going to touch the FMAP funding a little bit. And we'll see. The projections are interesting on Kaiser Family, and I'll send you the deck so you can see it. But it's not as dramatic as you are. And my opinion, working in a hospital and for an insurance company, and just now with some of the research that we're seeing, is there is not a lot of bridled talk about the entitlement programs where we're talking dollars, cents, coverage, benefits like we do in banking or we do in stocks or we do anything else. Where it's like, well, if they need it, they probably should keep it and we should keep spending it. Well, if you look at those spend curves, it's like, what are we going to spend? $6 trillion? We've got to figure out something that allows for that program to do it. And maybe you're right, through the employers, we figure some of that stuff out. But I think there is a subset of the population that's on Medicaid that probably should not be. And that we haven't figured that out. It's a very small percentage. I also think there's a subset of the population who does not care their level of health because they know that there's a safety net from the government that will fund it. And I had a statement in my first book that said, put down the cheeseburger, go for a walk. Very controversial. Very.
But Jonathan, you could say the same thing about Medicare. If we went down we could do the same argument on Medicare, that there's a ton of people on Medicare that absolutely could afford their own insurance. They just don't because they're I reach 65.
Yeah.
But we're paying for that. We're not reducing those because those people vote, right?
The difference
You're never
is
going to reduce
that was funded by ourselves to pay for that as we went. Medicaid's not. That's funded by a discretionary tax, but every time.
I understand, but it's the same. It's the same thing. You could do the same thing if they were actually willing to go after. They cut benefits from Medicare.
Yeah.
And save way more money than could Medicaid. Medicaid's a drop in the bucket.
Yeah, I think the issue surrounds that the way that's funded upstream is just different. But we'll see. Medicare won't get touched. It just won't.
I know, but I'm saying that they won't touch it because those people are actually voting for them.
Yeah.
Either party, they won't touch it. Because those people actually vote, and in theory, they matter, right?
Yeah. We'll see
I'm
what
not
happens.
saying they should take Medicare away. I'm just saying we never intended it to do what it's doing today. That was not why it was created.
Yeah. Well, I would argue Medicaid was never intended to be kind of the safety net that it is today either. So we got to figure something out. And what does that look like? The insured, I think some regulation or having the insured market through the employers maybe figure out, small group health insurance, understanding association plans. You're going to hear about that a little bit more too as we go forward, increasing those risk pools to not have that adverse selection happen. That's the other piece. Small employers just don't have a good lever to pull to keep their insurance right now, and it's unaffordable also. Like I said, I don't think it's going to get fixed. And I don't necessarily, the opinions of Jonathan aren't that of FinThrive, or I don't necessarily like them. I say this all the time. I don't tell you what you want to hear. I tell you what I think is going to happen. And that's whether it's right or wrong or not, it's an ethical discussion. But I just don't see, I'll go back to where I started. I don't see the budget getting balanced without them touching Medicaid. I just don't. Right, wrong, or indifferent. And the debate you and I are having today will be similar. Is it fair? Do we really feel there's that much fraud or abuse or waste or any of those things? Do we think that it should change? That's all irrelevant when it comes down to the dollars and where the budget's at.
It almost doesn't matter.
It's right up there with DEI
somewhere.
too. Like DEI, all that stuff's getting yanked. All the gender stuff's getting yanked. And that's this administration's kind of philosophy. Is it right or wrong? That's more of an ethical decision, and that there's definitely party lines on that, I think. It all costs money. And when I worked at a payer, I said something that I'm not happy about, but it makes sense more now than it did before, is I'm not saying you can't have it, but I'm not going to pay for it. And that's an interesting thing if you kind of wrap your head around that, because it gets back to where you started, that healthcare was and health insurance was never designed to pay or fund the things that it's being required to fund today. And I would argue Medicaid's probably the more disciplined of the paying mechanisms in terms of allowing folks in from an eligibility standpoint, having a defined benefit package with outcomes. I've actually been in the South with many MCOs that are doing a very good job at making money on the Medicaid population, real close to value-based care type arrangements, if that makes sense. But unless you're disciplined in that and you're all in and you're getting out of the acute care fee-for-service model,
right?
You can't do Medicaid in a fee-for-service model. It will not work, and it will not get funded that way. And I think the government's also going to try to push that a little bit to go, the benefits aren't, the faucet has to get turned down. And does that mean you got to look upstream and start looking at social determinants of health and start partnering with your county and public health departments and understanding outcomes and doing per capita risk agreements and starting to assume more risk and investing more in social care and those types of things that hospitals traditionally have not done? That becomes more challenging, but that's the only, I think, part of this spend and budget evaluation is going to look at that very closely as we move forward. We'll see. People think I'm wrong too. You've been very polite, Ben, but people think I'm not wrong as a person, but that they think Medicaid will never get touched. And I'm like, let's find a nice bottle of liquor to put on the table to bet to see what's going to happen, because I think it's going to get touched. I really
If
do.
anything, this administration has proved they will literally touch anything that's available and cut anything that's available. So I think on a lot of fronts,
like, oh no, they'll never touch it because those people should be on there and there's not really that much fraud. Blah, blah. And I'm like, they don't care. Care is a loose term. I would say they don't financially care. And it's kind of I would probably frame it that way. It's like, we've got to cut something, and it's just like your household budget. If we all took a 50% pay rate, Tina, you didn't get your raise, we talked about, and we would downsize our car or move to an apartment, or we would change our budget. The government's trying to do that as well, because we're broke too. As a country, we owe people a lot of money.
There's that.
So anyway, that was fun.
We'll see. Tina, what do you think?
Well, first of all, I want to thank Jonathan, because I feel like I understand so many more things. I think we should have him on once a quarter so he can come on and explain the world to me.
Yeah.
Yes. We'll start with the world.
Because honestly, I completely agree. Like, I think the current state of affairs is what it is. Like, not that they don't, again, to your point, they care about one thing, right? They have one goal and they're very focused on the goal, and whatever gets in the way of the goal is at risk, I suppose, is the
whatever gets away on the
state
goal.
of things.
Right. My kind of one sentence thing with the administration is it's a very radical approach to some rational ideas. And so and that kind of helps kind of tender it a little bit. It's a radical approach to some rational ideas. Rationally, we have to look at our country's healthcare and understand the cost, benefits, funding mechanisms, tax base, all that stuff. But they're radically approaching it with things like Doge and, running Medicare reels and Medicaid reels and finding pockets of things. And it's very, imagine a big piece of government cheese coming across with a butcher, just slabs of it are just falling over. My CFO at one of the organizations I worked on, he had another analogy. He said, let's just unplug it, see what happens. That's another analogy I would say this administration is doing. They're just unplugging things and seeing what the fallout is.
I'm a big burn it down kind of person.
With the layoffs at CMS, right? 80,000. Whoa, let's put 20% back. That looked like that actually turned off too many lights.
They do that. They're like, no, just cut. And then they're like, okay, wait, actually, we want to hire a few more people back.
So I was like, okay, so obviously they're making some radical decisions and don't understand it fully. But part of the reason is, I remember when I was at my hospital, we had several vendor contracts. We would turn some off just to see if it mattered. And if it didn't, we left them off. Because you didn't, especially if you inherited them, right? I inherited a lot of things too. And I'm like, who are these guys? And well, they do this and this for us. So, well, how have we demonstrated? No. Well, let's call them. If they said, yeah, we do this and this. And I'm like, can you show me? Nope. I'm like, well, I'd issue a term notice and we'd see what would happen. And, if a company can't do that, I strive this at FinThrive as well. Like, if we're not able to demonstrate our value to you in fairly real time, then we don't have any business doing business with you. We should be telling you like how we're making you faster, better, cheaper from a value standpoint. And if we're not doing that, then we deserve to not be doing business with you anymore, because we want to make sure we're providing value.
Now, a quick word from our sponsor. Physician billing underpayments pose a significant challenge for providers. Significant claim volume, low reimbursement, and the complexity and number of contracts means health systems often don't dedicate the time, resources, or technology to identify these opportunities. These needles in the haystack are difficult to locate without scalable, comprehensive technology. Switch RCM's intelligence platform addresses this challenge by identifying payment pattern variances at scale. By aggregating 100% of your 835 and 837 data, they uncover hidden insights and trends, enabling you to tackle underpayment opportunities and mitigate risks before they escalate into larger issues. Their algorithms both identify underpayments and also provide the ability to instantly categorize underpayment issues. This ensures you spend less time trying to connect the dots between all your issues and more time submitting accurate and consistent listings to payers, ultimately translating into quicker resolution and payment. Go to switchrcm.com for more information. Now back to the show.
Tina, you're a burn it down person. I want to hear about this.
No, remember, I always tell you, like, because when Ben and I first started talking about revenue cycle, because as of about 11 years ago, I was like everyone else. I was like, revenue cycle, what?
Yeah,
what is this?
What? What's that? I never heard of it. Then Ben sat me down and explained it to me, and I was like, okay, I got you. And then I started writing about it, and now I understand it. So I can write about it. That's like,
exactly.
That's what I can. That's the gift I have. And theoretically, I was like, but here's the thing, like, wouldn't it work better if you just like burn it down and rebuilt it anew, right? Rather than trying to take this old way we did it and like squish it into the new way we're doing it. Like, what if you just burn it down?
That is the way to do it. That is 100% the way to do it.
No, I know.
The problem is too many people lose. And so the argument is always like, well, the drug manufacturers and the device manufacturers, and then you start going lobby by lobby.
Yeah.
They're like the biggest
There's a lot
lobbyists.
Of power and greed, and
there's like
in
5 lobbyists that are like the largest of all of them, and it's like they're all in healthcare.
Yeah, there's a reason why the drugs aren't tariffed. There really is.
Let's just start there. Jonathan,
right. Well, hey, let's
start there.
What if we tariff them? Would that fund Medicaid? How about we do that? How about we tax them and would that fund Medicaid? How about that?
Yeah, I don't know.
We absolutely should. And Mark Cuban's gone all over this. Because he's basically like, he's actually trying to tear it down, and he's chosen pharmacy as like the
I love his
approach,
cost RX
and I love it. And but he's not. But you're right on the right track of like, well, in the tariffs, why don't we just do that why don't we just add a 50% tariff on any drug that comes in? I mean, we would literally crush it on that.
Yeah.
But the problem is someone's paying for that. They ultimately like someone's paying for it.
Yeah,
and it's probably
us are making money on that price as well. So it's interesting. Tina, I think it's a good question. I get that question a lot. Like, what would you build? And Ben brought, and there's so many losers that it's terrifying, right? I like talking about what works and where we should expand. So I think if you were to, like, imagine if you had like this really beautiful spaceship, from Lego, and the Millennium Falcon, and it dropped. There's parts of that you would probably keep, like the cabin, that's cool with Chewie and Han and the little guns on each end and the radar. So like, and you'd start adding other pieces to it to keep it there. The lame part with the horn in the front, you probably get rid of, and the cool blue lights, you'd keep it. My point back to healthcare is there's parts that work. I would argue employer-based insurance works for the most part in terms of the employees and what they have. The price doesn't, and the mechanisms, but no one ever talks about the 98% of claims that do get paid, and when we need something, how well it is. And we've got really good healthcare, and it's expensive. Yes, employers are paying too much for it. But when you need something and you are an employee and you have good insurance, it works. The claims get paid in a fairly efficient way. They worked. And Medicare, frankly, was one of my favorite payers. They paid every 2 weeks, and they told me exactly why I got paid and why I didn't. and I could fix it the next week. Medicare Advantage, I could use a Ouija board and wouldn't get close. And some of the managed Medicaid parts of commercial insurance on the fully risk insured and Medicare population work. I really like Ben's idea about kind of separating out the concierge part of it, the wellness part of it, to where in my book, I talk about you can't have an affordable insurance for an unaffordable product, and you just can't. So you've got to make the product affordable and make some of that out of pocket more there. Just like I call it vacuums too. Like I don't own a Dyson. I don't know if you guys do. I have nothing against Dyson, but I refuse to spend that much money on something that sucks. It cracks me up. Oh. And I've heard they're really
literally
good.
Is not a good vacuum, so don't buy it.
Like in healthcare, it's like, oh no, I want that. I want the 132 slice CT scanner, and I want the stent out of Switzerland that saved blah blah blah. And you will save my life. I don't care what the cost is. And it's like, or you will give me the GLP-1 drug Ozempic and let me have it forever, and I can eat as many cheeseburgers as I want because now there's this drug that just makes the fat go away, and I will never get diabetes. It's like, well, wait a minute, who's paying for that? Like, and are we paying for that, or is the patient paying for that? And should those drugs be $500 a pill? They maybe are. I don't know. But the insurance company when I work there, it's like, why am I paying for that drug when it's not designed for that? And that part becomes weird, right? So those two pieces I put. There's parts of Medicaid that work too, like the managed part in the South I've seen. But there's parts that are broken. But I would start with those three big parts of that Millennial Falcon and kind of build that back. And then you're kind of left with the uninsured and the people that don't qualify or can't afford. And that I think is going to have to be fixed through some level of tax reform and coverage. And I don't know what that bridge association looks like. I'm a big proponent of lowering the Medicare enrollment age. Because it's a good plan. It's the largest health plan in the world. It actually has pretty efficient outcomes except for end of life. I'm a big proponent of reducing the enrollment on the Medicaid side because I think I just saw it at the hospital. There's just a population that is within that plan that could have something else but has chosen or demonstrated that they couldn't or can't. Can't's one of those words that drives me up the wall. I can't get insurance. Yes, you can. You're just making a choice. And it's not, you haven't changed your lifestyle to get to that. And I'm hoping some of that stuff brings the whole system down. What we can't do, Tina, and then I'll shut up, is we can't blow it all up and say, all right, everybody come, because then you're going to have something called adverse selection, which is, you learn that when you get your master's degree, but that is the rich people. It turns into 17th century London. You have everybody in a castle.
Sure.
And they get whatever they want.
Right.
And
they have concierge medicine. Everybody
Lord of the Flies,
jack
right?
squat. And it immediately becomes this caste system to where the people that really need insurance, it's priced so far high, and everyone who doesn't really need it doesn't fund it. And you're seeing that now. A lot of I don't have the stats, but a lot of the millennial generation is actually uninsured, if I remember right, from a pie standpoint. And because of that, they're not funding the rest of the pool. And it's just an interesting model to kind of wrap your head around. Like, Massachusetts has got a really cool program where you can't drive a car unless you have health insurance. They function the same way. So like when you go get your driver's license, you have to prove that you have auto. You also have to prove you have health insurance there. And health insurance is required in the state of Massachusetts. You have to have some mechanism, be it the states, something else, and that helps that pool stay solid. And they've got like a 3% uninsured rate, as does Hawaii. They don't have that compulsory thing, but interesting stuff. I could tell I've bored you, man. I'm sorry. Or you're just you're deep thought.
Wait, where are we?
Thinking.
No, I'm kidding. No, I just think the other thing is Tina and I are a good example. Now I have TARP, and so I have insurance. I get a stipend.
Through the
we give
exchange,
stipends out
through
the exchange. Yeah. But I've been on the exchange for 8+ years because I've been on my own.
Yeah.
And I think that there's a lot of like the entrepreneur kind of economy is changed like the next generations because they're coming out and kind of working independent and doing lots of different jobs. And they're also like, well, why am I getting insurance? Because look at how much I can't afford that. I can't afford that and live. And so I do see it as kind of like the next generation being not really employer based, if that makes sense, as a percentage of like total being significant. I do see a change. Like there's going to be rubber's going to meet the road at some point, and it's going to be like, holy crap, what do we do with those guys? Because to your point, they're not going to qualify for Medicaid regardless of what we change, because they make money, but they also don't have insurance. And
I
so
call them donut hole patients. Yeah, and we don't have a good
that's
way
going
to
to be
make
a
a
problem.
donut hole. And it's tough. I think the exchange plans have too small of a risk pool right now. And maybe there's a way to kind of share that to understand, how to adversely select that or to get around that.
It's the state
They're
problem.
also administered
There's still
by
a
the
state
government.
problem here.
Yeah.
The problem is I have Blue Cross Blue Shield of Michigan.
Yeah.
If it was just Blue Cross Blue Shield or whatever, then it wouldn't, and it was a cajillion people in there, it wouldn't matter. You have a risk pool that's large. This state issue is so stupid to me. I do not understand it.
Yeah, that was on the federal docket to talk about.
I remember
removing those brokerage rules. It's an FTC rule that's out there that talks about
it was in the ACA and they got taken out.
Yeah, right. Yeah, it's a big deal. And I think if you had national insurance lines, I mean, I worked for a national insurer. It was much easier to insure. You're gonna laugh. A Kmart. That's how old I am. Than it was to insure the others. So.
I got news for you, brother. They just tore down Kmart's corporate headquarters here in Detroit. I literally, Tina, I drove by it yesterday, and I was like, it was gone.
It's
like,
empty
holy
land.
Crap.
Yeah.
It was. I mean, it wasn't Kmart for a long time, but it was just. But I did find it fascinating. That whole vestige is gone. Can you believe that?
Yeah, it's like Sears and all those things.
Blockbuster and everything else.
Yeah,
crazy.
Yeah.
Anyways, we've digressed. I don't know. We got into another subject.
Also, just to your point, Jonathan, too, I just really wish that people, and I know this is going to sound like mom action, old white lady.
It's okay.
I just really wish people would take care of themselves.
Yeah.
I think that is the missing piece. Like, this is a huge missing piece.
Yeah.
Is like, I don't know,
They know
eat right. To your point, go for a walk.
The government's got us. I don't care. I'll eat.
Right, like,
And I would argue, can I just argue for a second on this? Because I agree with Tina 100%. Tina and I have had this conversation. Jonathan, I think you're my age, so I think we were roughly the same age.
Yeah.
My friends and their parents, now, my mom is gone, so, and my dad's basically like an invalid, but like my friends' parents do not take care of themselves. They don't. They watch Fox News or MSNBC all day and CSI. They don't drink water. Most of them are drinking, and they don't do it. They just go out to eat. I'm like, what is this? Like, and my buddy's trying to get his mom to come live with him. Just be like, when she's here, I got her drinking water. I got her walking. She's like a different person 5 days in. But when she first starts, she can't even get up the stairs. I'm like,
right.
He's like, they could live like 10, 15 years longer, but they don't want to. And so I don't know if it's like World War II generation getting older now and being like, screw it, we did our time, but they don't take care of themselves. I'm not even talking about young kids. I'm talking about like people in their 65 and older right now. Most of them are not doing any work. I just find it fascinating.
Yeah, rate banding is something else one of my books talked about, and like I kind of alluded to it a little bit, like with your car insurance when you have a 16-year-old.
No, it's true.
Imagine an insurance mechanism that changes based off your cholesterol or your steps that you got in that day or your BMI.
We've been talking about that for years. No one's doing it.
Into discriminatory entitlement versus discrimination type stuff. But I don't know. I think, maybe the plan that you have off the government is so limited that you can get incentives. There's wellness. I have a wellness chapter in there too that talks about what you talked about, Tina. And, maybe you get $50 off your premium a month that goes back in your pocket, or $250 a premium if your BMI goes down by 1/10 of a point, or your cholesterol, whatever, or you can demonstrate your, whatever change, your heart rate went down or whatever. Those have, I see some light there, and I see that as kind of a path to some of the value-based care stuff. But yeah, to be frank, we're the opposite. I could rattle off 100 statistics, but in my first book, I talk about 90% of the costs from healthcare come from 10% of the population. And that 10% of the population, I think like 95% of them have one or more chronic conditions. And the number one is obesity, and then diabetes, then congestive heart failure, then pneumonia, and
all related to the
market.
obesity.
Yep, the market's the hospitals are trying to figure that out a little bit, but then they're offering bariatric surgery and GLP-1 drugs and it's like, well, wait a minute, that's like excusing it, not addressing it, and it's perpetuating cost and unhealthy behaviors versus trying to manage it. And we get really wrapped around the axle of society when you start doing that type of thing, but I feel fundamentally the reason why healthcare is so screwed up today is because there's a third-party payment system. And we all got a bill in the mail when we were in college or from our dad, when we first started out to pay for our own stuff. And we didn't give a crap about that number in the upper right corner that was 10x, 12x, 15x of what it is. We only cared about the little green one and whether it said 0, 10, 20, or 30. There's a reason why prescription drugs have small copays. It's the highest utilized, most expensive one. And it's also the most customer facing. So it's got the most price sensitivity to any other benefit.
It's so true.
It's the most expensive because it's got the most indirect cost. And you start looking at that. If we start cost sharing, and now deductibles were supposed to try to fix that, but it was not a brilliant idea to say, oh, if people have to pay more, they'll go shop for care that's better. Transparency is blown up in the face of our industry. Good idea, I think, in terms of helping people understand transparently what costs are. Bad idea to have the insurance mechanism fund it that way, because that's just passed debt down to hospitals. I'm fascinated that hospitals have to collect copays. Why don't insurance companies collect them? It fascinates me.
Oh, this is what I've been researching. So I've been researching the. I am all on this side because this is what my latest thing I've been kind of digging into. Actually, how I got to like the thing I talked about earlier.
Yeah.
Was I started researching, like, how did we end up with deductibles? Like, how did the cost sharing thing start?
Yeah.
So that's what I've been researching. And it's a fascinating kind of dive because it all kind of goes centered to this RAND study in 1981, which finished in 1981, which is just fascinating on a lot of levels because it was something I was taught in grad school. I'm sure you were too. It was like, well, yep, any amount of copay will. But it has been fascinating to kind of see, like, actually, like, it doesn't work. And there's a bunch of other issues with it associated with, like, if I have $1,000 deductible and as someone who's poor has $1,000 deductible, those are two very, very different things.
Yep.
And they have very different, like, effects on, I'm not going to not go get services because I can afford it.
Yeah.
Someone who can't is literally going to avoid everything possible, regardless if they have insurance or not.
Yep, and then snowball later, too.
So and then it snowballs really later, and then hospitals become subprime lenders, and they didn't even know they were.
They are.
Fascinating.
Yeah, they absolutely are. Yeah, it's interesting. We'll see. I think cost sharing is a way to kind of do some reform, too. And I think that would actually make premiums go down at some point, and the insurance companies won't want that to happen. If you look at those stats, it's amazing how much money is being made in all the different entities, hospital, payer, everywhere else. Just the growth paths it's astounding, and it has to level out. And I'll end with this: if we don't try to fix it, the government's going to try to fix it. And we all know what happens when the government tries to fix things. And so that's where we're at. Is we're kind of in this timeout. Like, fine, I'm going to put rules out there and start cutting stuff if you guys can't budget yourselves.
If we don't start fixing it, Elon Musk is going to fix it, and nobody wants that. So
we got
start on with
random reports and saying, let's just
cut this.
Looks like what is ESRD anyway? Who cares? We're not paying for it anymore.
Yep. Doesn't matter.
So,
all right, Jonathan, thanks so much for joining us. It was a great discussion.
I hope you enjoyed it. Yeah, I hope you both enjoyed it. So, yeah,
sure.
We'll be in touch. I think I'm coming on your podcast soon, so we'll see.
We'll figure it out. Nice meeting you, Tina. Keep him in line for me. He's a good guy, will you?
I'll try.
My good friends, my good friends, my good friends.